Welcome to the Shockwave Therapy Podcast. My name is James Woolwich, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Today we are joined by Stuart Brown, podiatrist and educator who's been using shockwave therapy for as long as anyone I've known. He's got excellent insight into the use of focused shockwave in particular, and has definitely used that more than anyone I know in this country. So he's going to be taking us through a few of his ideas on how he uses a shockwave therapy to support the treatment of lower extremity problems in particular. So welcome, Stuart. So good evening, Stuart. Thanks for joining us on this podcast, and I wanted to get your position on a few things that I haven't tackled in the other podcasts that I've done. One is that you're a podiatrist, and the other guys have been physios. And the other thing is to try and tackle a bit of the focused shockwave as opposed to just radial, because I know that you're a big advocate of that. So welcome along. So if we can just start off, could you just give us a brief overview for people that haven't heard of you, about your career so far and how you got into focused shockwave?
Yeah, hi James, thanks for having me for starters. Before we start, that was one of the things I was going to tackle actually. I think it's great that you're an osteopath and you're interviewing me here, a podiatrist, and did some physios before, and I think
sure
that's I think time is kind of helping with that. Like, kind of, we are coming more crossovered.
Yeah.
And I think we can all learn from each other. I mean, there's no point saying I'm the best and this is all that matters. And I think that's really developing. Having, I know you work in a multidisciplinary clinic yourself, don't you?
Yes.
And I think it makes a big difference having that crossover. So I think it's great that we're doing this. And I think your interviews previous, your other podcasts, they're really good.
Thank you very much.
Yourself and the guests, well, that's up to today anyway. So yeah. Yeah. Okay. Who am I? Right then, so basically I'm an NSK podiatrist, so my degree's in podiatry anyway, but I've trained in a lot of different other disciplines, a lot of courses over the years. I work in private sector, which I think is very different remit to, say, working in the NHS. I work at my own clinic 2 to 3 days a week, and then I work in an elite multidisciplinary clinic called Core Health and Wellness, where chiropractors, Stephen Vosson's the main guy there, and we all got GPs and physios, osteos, chiros, sports therapists. So yeah, I get a good look at what other people are doing, and we have general meetings and shared notes, and
sure.
So it's not just about me being a podiatrist, I think.
Yeah. So when did your journey begin with using shockwave then?
Shockwave, it was roughly about 5 years ago. I was doing prolotherapy anyway, and among other therapies that I was doing. And prolotherapy is quite invasive, and it was quite random, the knock-on effects. But the patients obviously don't have having injections in them, and they're questioning whether it's going to work, and also some of them were just anti-needles, so I wasn't probably getting to as many people as I wanted to.
Mm-hmm.
And I saw shockwave as a maybe a lot easier, safer route of doing something similar. So that's why I got into shockwave in the first place. And that was roughly about 5 years ago. But I really didn't realise how good it was at the time, to be honest.
Yeah.
I kind of got into it thinking, I could do, just support kind of the things I was doing at the time, which was maybe plantar fasciitis and Achilles tendonitis. But
sure.
I've moved on a long way from there now.
Yeah, I know you have, and we'll talk about that in a bit. So at what point did then you, if you like, upgrade to getting the focused device?
Well, I'd wanted the focus for a year or two before, but it's very hard to justify that to your wife, isn't it? You've got a full clinic, you're getting great results, and you want to spend 25-30 grand on a and a device that, as far as she's concerned, is exactly the same. So.
Yeah, sure. I can see that one. So what year did you buy into that?
I think it was. I think I went to Switzerland to Storts and saw the setup, and I kind of, that spurred me on a little bit more. Like again, mixing with other people who are using the machine.
Sure.
And that community feeling, and I'm not the only one doing it.
Yeah.
So yeah, that made a big difference, especially like staying on the WhatsApp group when we came back, and that kind of spurred you on a bit more as well.
Yeah, so, sure. That's been helpful. That.
Yeah, it is. It kind of, even working in a multidisciplinary clinic myself, it still gave me that support outside of that. But I kind of wanted it, as I say, about 2-3 years ago, and I couldn't find a way of justifying it, the kind of extra costs. Yeah. Even though I knew, but I think the justification is that, you're doing it for your patients at the end of the day.
Yes,
you do have to kind of make a living out of it, and you have to justify things. But at the end of the day, I knew I could do better, and every time a patient was coming in, I was like, right, yeah, but this could maybe work better for that.
Yes.
And that's the big problem I have now at the moment, because I work at the two clinics. The one clinic's got a focus shockwave, and the other clinic hasn't.
Yes.
And every time I'm doing a patient, it's like, this would work so much better if I had the two in combination.
It's the one downside, isn't it? Because the Radial, we have the same device, I think, and it's portable, and I use it in my other clinic, but the focus just isn't portable, is it? That's the downside.
Johnny lent me one a couple of years back when my Radial was broke, and I didn't have a clue what I was doing. I didn't know what the heads were. I didn't have the heads. I just had the machine. But I lumped it between clinics for a week, and I decided I wouldn't be doing that again.
That's pretty brave of you to do that, I think. Actually, when I put that to Storts, I was highly recommended that I shouldn't do that. So I don't think I will. So now you're using, if you like, you've got both at your disposal. And I think there's a lot of questions get asked when I do some teaching that, should people dive in and buy it? And I always give the advice, look, go and get a Radial device first. I've said that on the other podcast. That's the 90% go-to thing for the tendinopathies. But I now have obviously got a focus over the last 6 or 7 months. I got mine, and like you, it opens up a new group of patients with different conditions, because it works in a slightly different way. So I always give advice.
And the results.
Yeah, the results are faster coming, because it's just about putting more energy into the tissue, isn't it? So when if we can go back just a tiny bit, so you've used lots of different. Have you used other electrotherapy modalities before, and where do you see Shockwave fitting in terms of the impact it has on patients relative to those?
I don't use electrotherapies. I use a lot of different therapies, like biomechanics, insoles. I'm not a normal traditional podiatrist who relies on insoles. I'd rather get the person better, and then the insoles are supporting factor.
Yes.
And I think the Shockwave, again, is a supporting factor. It's part of the jigsaw.
Yeah.
And, it's a blooming good part. It really is. But I do fascia release, and then again, like when I find a bit of fascia that's damaged, I bring the Shockwave in and help heal that situation with manipulation, which helps desensitize tissue to allow Shockwaves to work better and on areas that are painful. Yeah. I think Shockwave for the lower limb is very. I mean, I do a lot of upper body and shoulders and necks and elbows and all the rest of it, and hips.
If we it wasn't one of my planned questions, but that just reminds me, when I did my last course in London 3 or 4 months ago, and there was about 4 or 5 podiatrists on that course, and they were asking me afterwards, because obviously I was tackling all the tendinopathies, and a couple of them were then saying to me, would we be able to treat those body parts, because as podiatrists, of course, it's usually hip and below, isn't it? There are certain rough guidelines that you can only treat up to the knee or some other such stuff. And I know that we've had this chat at the British Shockwave event that we went to. But so where do you see it as a podiatrist giving advice to another podiatrist? Are there any rules and regulations?
It'd be nice if there was a bridge course at some point, if podiatrists want to go down that route.
Yeah.
I don't think, if it's not in your remit. I mean, I've done a lot of training outside, so I've worked on the shoulders previously, and I do before Shockwave.
Yeah.
So I can do it because of my other qualifications, but the reality is if you're not qualified and there isn't a bridge course at the moment, there isn't.
Yeah.
Then I think maybe you may do it to your mate down the road who's not paying or whatever. But the reality is I'd probably leave it alone, to be honest. it's not in your remit, then you shouldn't be doing it. It's not in your insurance.
Yeah.
So you've got to be safe. But I mean, it is a question, because a lot of people out there, osteos and physios, don't realise that, you give a podiatrist a shockwave machine and you're telling them they can do all these things, but can they? No, I don't think they can, really.
Yeah, sure.
I think there needs to be a bridge course, and I think it'd be good if there was one done eventually.
Yeah.
But even then, you've got to make the podiatrist. I think shockwave's pretty safe generally, so
yes,
I think it's potentially possible, but not. Maybe other things it isn't so possible with, but the shockwave, I think it is. Yeah. So. Yeah.
Okay. All right. So when you've moved now,
can I go back to that as well?
Yeah.
What the podiatrist should have been saying, really, I feel, is that I had a radial for a long time before I had a focused shockwave, and I had a lot of success with outside of the tendinopathies. I think it was my first patient I treated had a 4-foot neuroma, I think,
mm-hmm.
and they were basically saying they're needle phobic, so they couldn't have the prolotherapy.
Mm-hmm.
So I said, well, look, I can't promise you anything. I'll give you some shockwaves. If it works, great. If it doesn't, then we'll we'll try one way or the other to get around the needle phobia.
Yeah.
So we did. I think it was back then. It was 3 sessions, wasn't it? It was
the assert thing. Yeah.
It was like kind of 500 shots at 1.5, and then another 1,500 at 2.5. Mm-hmm. And they struggled through it a little bit at that point. I mean, I wouldn't have done it like that now, but they got 50-60% better after the 3 treatments. I thought, well, that's not bad.
Yeah.
But I said to them, look, if it comes back or you want it doing again, then we're going to have to go back to the injections. But about a month later, I bumped into them and they said, I need to see you, Stuart. Okay. So I said, but this time it'll be with injections. And they said, no, not that. My foot's 100. I haven't had a problem since I saw you. So first of all, that told me it carries on working after you finish the treatments.
Yes.
Which I think is very important, because I think patients don't get that straight away.
Yeah.
And even as therapists, I think we get used to getting good results, and then we expect them then, and when one's not happening within a couple of sessions, you kind of start going, oh shoot, what's happening now?
Yes. Yeah.
But basically, what happened is it worked. So they wanted a knee doing that. But that led me to think, well, what can I treat with this? And I've got countless stories. But I think the upshot on it is podiatrists, they're aware of tendinopathies, but the reality is, I've had one person, first treatment, they were booked into surgery that day, actually. And 3 years later, they haven't had the surgery, they haven't had any pain.
Yeah.
Okay, they've had 1 or 2 twinges where they've come back, say last year, I think it was.
Yeah.
And they just had a top up, but they haven't had any pain in that joint, they haven't had surgery. Yeah. And I'd probably do, I don't know, 2-3 of them a month. So you had that over 3 years, it's quite a few, with about an 80% success rate, I reckon.
Yes.
Then 4-foot, dorsal foot, ankle, Achilles, plantar fascia, calf. But as I say, I'd do the whole body. But as a podiatrist, there's so much more they can do.
And for the non-tendinopathy, do you see that as the particularly effective role of the focused shockwave?
Well, going back to that again, remember I said I hadn't got a focus at this point.
Yeah.
So.
But now you have. Would you choose to use it preferentially for the other disorders of the foot? I'm thinking, metatarsophalangeal joint irritation, OA, changes in the large toe, and so on and so forth. Would you tend to use focused instead of radial for those things?
They're 2 separate machines. They shouldn't really be compared. They work together, not apart, I think.
Right. Do you always combine?
You're right in what you said. You're going to have a radial first, aren't you?
Yeah.
It's a better learning tool. There's more feedback easily.
Yeah.
And you're less likely to do damage. And I think, I'd use the radial, but then I'd tidy up some of the bits with the focus. I mean, the focus picks up things that the radial doesn't, and the radial sometimes occasionally does it the opposite way around.
So that's an interesting point, because a lot of people get confused about that, and you quite rightly said you use the 2 together. So are there any occasions where you would just use one and not the other for any particular reason?
I scan large areas of tissue with a D20 on radial.
Yeah.
I think, you're doing a calf or a hamstring. Yeah, maybe if you've got an idea of where the problem is in the hamstring, you're all right. But I think I quickly scan with a radial and then the larger tissue areas. But I use 90% of the time, 95%, I use the combination of the two. Right.
And what do you? Because I get asked this question a lot. What sort of things do you look for in the case history and the examination as to determine how many sessions you might provide the patient with, or do you use a set? So some practitioners out there use a set. Everyone gets 6 sessions. I don't follow that personally, but what do you use as a guide?
I think it's Paul, isn't it? I think Paul's idea of using 6 is very good. I think it's just whether you can sell that to the patients to start with. I work off patient response within treatment and effect. So I kind of normally standardly say to the patient, well, let's do 4 and see where you are at 4.
Yeah.
And then I judge on response, and then generally I go to maintenance at 2 weeks. If they're responding well, I go to a month, and then if they're responding well, I say, well, let's see how you get on. And it depends on what the problem is and the underlying condition and the chronicity of it and what they're doing. I mean, if they're sports, if they're kind of top-level athletes and they're going backwards and forwards in the sport and they've got damage to the area, then maybe we need to look at it a bit longer. I don't know. It is really response-led, mine, but I do generally 4, a 2-week gap, and then a month gap.
So you spread out your treatments by 2 weeks, do you?
At the 4-week point, yeah. And if I'm getting a lot of feedback off the Shockwave machine...
Oh, so sorry, just to clarify, you see the first 4 sessions at weekly intervals?
Yeah, definitely. But unless, they've come from miles away.
Yes.
Or it's a professional sports person, they're going to be on the pitch on Saturday.
Yeah.
And then, maybe we'll suit to alter. But... I generally, in a day-to-day clinic, with taking out, abnormal patients that are coming from different reasons.
Yeah.
It's 1 a week for 4 weeks, then split it to the 2 weeks after that as a maintenance. Then if they're doing well, then I split it to a month. If they're not doing so well, I'd maybe give them another 1 at 2 weeks after that. But it depends on response, and you kind of learn things about the patient as you're going along.
Yeah.
And that makes a big difference.
Yeah. Okay. All right. And would you still be stopping at 6 or 7, or the way you're sort of saying is that you might see them every month using Shockwave ongoing?
I've got some patients who got chronic arthritis, and there's very little mobility through the ankle.
Sure.
And, or wherever the problem is, and that, or they've got a repetitive strain job. And yes, they get better, and it's generally invariably them that wants to have the maintenance. It's not necessarily me. I see a role in it as a maintenance thing. Not only, I think when I first started, I had very basic guidelines.
Yeah.
And it was just like, I do 3 treatments after 6 months of chronic pain. They've tried everything else. They've tried steroid injections, then you can treat them. But we've moved a long way from there now, hopefully. So.
Sure. Okay. If we could just take a little bit of a turn at this point, because I know that you use the focus Shockwave for one of its usefulnesses, if that's a word, which is an emerging modality in erectile dysfunction. So you have a specific clinic where you're using it for that, and you've been using it for quite some time. Can you just give us a little bit of a précis on how that developed and how it's going now?
The reason I actually justified it to Mrs. Brown was the fact that the erectile dysfunction, the pricing is slightly different, and also it's a different field of treatment. So that was how I justified moving up from radial to focus for myself. In joining, sorry.
Yeah.
So that's the reason I started doing it. But when you start treating these cases, it's a very interesting thing, and it's a very good big role as well. I mean, you've got these people who often maybe they don't feel themselves.
Yeah.
And maybe a bit depressed. And also this is a lifeline that you can help them, not on just by using the Shockwave. You kind of talk about sleep.
Yeah.
You talk about diet. You talk about stress. Mm-hmm. And this is a wake-up call. This is canary down the mind. This is let's get a testosterone test and things like that. And,
yes.
you know, like kind of this is a warning saying like, you know, something's not quite going right here. So let's see if we can. You've got a window of opportunity to actually help the person.
Yeah.
So I think that brings in a lot of the skills from when I was a lot younger, when I used to do a lot of therapies. But it definitely, yeah, it's an interesting field. And I think the thing is, as I was saying about when I started using it on the forefront, it's tissue at the end of the day.
Yeah.
When I train people, I kind of get out 5 studies for each area. 5 studies for fascia, 5 studies for muscle, 5 studies for bone, and then basically, like, well, you're covering the whole body virtually in those areas. If you kind of get rid of all those, you know, you can treat all those areas, and yeah, tissue's tissue, and it helps repair and heal tissue. Yeah. So why not is the answer. I think we've had this before. It's like, why not treat instead of why should I treat?
Yeah, I think
it's going really well. That side of it.
Yeah, good. So what do you do 6 sessions, 12 sessions? Are they weekly? How does that?
Yeah, at the present we're doing 6 sessions, 1 a week for 6 weeks. But we just joined up with London Andrology actually. Right. And I think we're going to have them like kind of assessing the patients, and they do go into 12 sessions. Right. So yeah, so we're doing 6 at the moment because that's the protocols. And again, like when I started normal Shockwave, you know, I was following protocol on this, but it's slowly developing, and I'm slowly changing and seeing what works better and what doesn't. Yeah. And then developing with it. So yeah. And
this, I'm assuming, because I've looked into this myself. You're trying to pick out those with vasculogenic ED, obviously. And do you prefer to see the group that are already responsive to medication, or do you see patients that aren't responsive to medication?
Well, I think that's the easy answer, isn't it? You go with the group that are responsive to medication. Yeah. I mean, I think if it's outside of that, although there's like a mixture of history and you know, medication, then that's when I refer to someone else and say, well, look. What do you think? Yeah. You know, and then wait for them to come back or not. But yeah, I think the easy answer is I jump on the ones that got medication. Yeah. And like you know you're onto kind of a winner that I should think then generally. Well, it seems to be anyway. Yeah, sure. Roughly 80% success with that as well. Yeah.
And because you've now been using it quite a while, I mean, I think that a few people that we've had ask us about this in clinic are saying to us, well, if it, you know, if it, you know, because they're quite happy at that particular point in their lives, even if they saw it improve 50-60%, they're quite happy with the outcomes. But what they always ask is, how long does it last? So what's your experience of being with that? Are people coming back 6 months later saying everything's gone back to where it was, or are you seeing people where the effects last for longer than 6 months?
No. I mean, if you look at the research that is done, you know, the year down the line, that these people are still. You know, functioning well, and I think it's the same as MSK. It's quite funny actually. Whenever I talk MSK, I relate to ED. Yeah. And whenever I talk about ED, I relate to MSK because it comes back to the tissue is tissue at the end of the day. Mm. And you know, if you've had it for like 1 month, 2 months, and you kind of have the treatment, then you're going to get better quicker and it's going to last longer. But then if you've kind of slid down the hill a little bit further, yeah, and you're more chronic, then you know. Potentially the underlying cause is still there, yeah, and it's something that you need to kind of think about and look after, yeah. Whether that be maintenance treatment or whether it's health yourself. But I think, you know, again, it's Shockwave is long lasting. I think it works better over a longer period of time than shorter, to be honest.
Sure. Okay. All right. I think the other thing that we were going to talk about, because I know that we both agreed on it on in principle, because we chat through these things about the concept of education. Because I have this on the previous podcast. I mean, I've tried to make this podcast as not non-denominational about whether it be STORTS or, you know, EMS, Swiss dollar class, so forth. And I think you probably have the same kind of opinion on that. I mean, but the thing that's lacking at the moment is a sort of agreed upon educational platform that we should all be ascribed to. I mean, what are your thoughts on that?
I think it's pretty non-existent at the moment. I think there's people like yourself who do you know, one-off courses that, you know, is that getting hold of a small group of like 6 to 8 people and saying, well, here's the machine, now you can do it like this, or when the patient does that, you know, there's no real hands-on training. I mean, it's better now than when I started. I kind of got the machine. I didn't even realise the heads came off. It took me a year to work that one out. But basically, I think it's giving Shockwave a bad name. I think apart from these other machines coming into the country that we're not sure about, but I think the actual training side of it is because there's very little to none. I mean, some companies haven't got any at all. I have a lot of people who've just bought a Shockwave and they kind of don't realise what they're doing with it. And they're treating patients and they're saying, can I treat this? And I get emails from people and then they say, well, I did this and the patient came back in agony. And I'm like, yeah, well, you didn't do this, this and this, and have you used this? Yeah. And, I've had people complaining as well. And that's not just private. I've had people coming from the NHS and they've complained that the person hurt them and they did it too high. And I think it's because a lot of people don't understand the actual machine or how to shockwave. Yes. They don't use the different heads, they don't use the different frequencies, the bars. They just follow protocols and that's the area of pain, let's blast it, or that's the surrounding tissue, let's blast it, as I had with one footballer last week. Yeah. And then as soon as we did the actual area, suddenly, lo and behold, he got better.
I think I have the same opinion on all of that, and you try and get it across in a one-day course, and you know as well as I do that's just the bit that teaches you how the car works.
You've got to have the small amount of numbers as well to get
there,
sure. Like, I think it's different. You need it structured. I think you need a basic level for like, oh, this is the machine, this is what it can do it to a degree, and then like, oh, I've got used to the machine now. How can I use it? And then like kind of what we're developing now, like with the advanced course, and there is an intermediate course as well in between that.
Oh, is there? I didn't know. I know about that. And then, while we're on that, people go, what are we talking about? But actually, we both work for Venn Healthcare as such, and work with the Storts equipment, don't we? As much as we don't want to be non-denominational.
I have worked with other people, but I'm just purely with Storts now.
Yeah. And so let's give you a shameless plug. So when is your course? Is it next month up in Harrogate somewhere, isn't it? Or is that right?
No,
am I completely wrong?
You're completely wrong.
Oh my goodness.
No, it's let me get this dead right, because I know I've got a lot of things. September the 28th, and it's in the multidisciplinary clinic that I work in Warwick, and it's a very nice building and very nice setup. Right. And then we're doing an advanced workshop, but it will include the intermediate level, which will be 2 separate courses next year. Right. So next year that will be intermediate, so you learn how to use the different frequencies, the heads properly, what heads are available, and I have a big thing about, it's not about the numbers, it's about desensitization and patient feedback, and that's the way I work with Shockwave, and I've kind of learned that myself over the years. And then I think when I went to Switzerland, I kind of realised they're probably doing it very similar. Yeah. But yeah, we're doing that course, and then I always thought it was, at the end of the day, I'm not an osteopath or a chiropractor, and I'd like to learn off someone how they do backs and necks. And so realistically, I said, well, why don't we have 3 split advanced courses when, like myself, doing podiatry, maybe like kind of doing the lower limb. Yeah. I mean, doing someone's first joint or dorsal foot is totally different to shoving it in on the glute or onto this shoulder where you can just blast away. Yeah, sure. So, you've got to kind of learn how to treat these areas and when to and when not to, kind of thing. And so we kind of, I think that we have a advanced lower limb, advanced midsection, and advanced upper. So that, there's like 3-4 different levels of learning there. Yeah, but, good. I think it could go a lot further than that, and I've got a lot of ideas in my head of where it could go, but we'll see. Well, I'll chat about you, because I think that we're both going to be at the London one, aren't we? Which is in November. Yeah, I'm looking forward to that. Yeah. Okay. Well, look, I think that's as much as I wanted to talk about. I think. Have you got anything else that you'd want to say about your unbelievable enthusiasm about Shockwave? I think that's enough for today. You can always come back to me another time, and I have got other things in my head, but I'll leave it at that. We're going to start opening a whole new pathway if I start talking about what I'm thinking of. Fine. Well, everyone else, I've said that when this has just been a start for me, so when I get about 4 or 5 under my belt, we'll revisit some subjects and talk about them. But thanks. Yeah, there's some stuff on the training, definitely, I kind of want to go over. Yeah. I could go more specifically into the lower limb, but I think we'll leave it there. Okay. All right. Well, look, thank you very much for joining us, and we will no doubt speak again. Cheers, Stuart. Thank you, James.